So I'm going to bring on next to introduce our next speaker to go into that area. One of our AFRAM members and our UHW Executive Board members as well, Ms. Heather Wright.
Good evening, everybody. My name is Heather Wright, and I have been given the honor and pleasure of introducing our next panelist, Dr. Jaylen Wright, PhD, Perinatal Clinical Research Associate, Boston Medical Center. Jaylen was born in San Jose, California. He ran track and graduated from Texas A&M University, and then attended the University of Texas at Austin, where he earned both his master's and PhD in health behavior and health education, with concentrations in counseling and qualitative research methods. In general, his research involves examining and improving the health literacy, psychological health, and well-being of racial, ethnic, marginalized, and underrepresented individuals, families, and communities. As an educator, Jaylen has taught courses on health equity, qualitative research methods, type 2 diabetes education, multicultural counseling, physical fitness, and social determinants of health. Outside of school, in his free time, Jaylen loves to read and go to the movies, and he is a wonderful baker. His specialty is cupcakes. And he always makes time to call both of his grandmas on Sunday evenings. And now, my shining light, my sunshine, Jaylen.
That's my mother, folks. Thank you. Hello, everyone. Good evening. I am here actually in Austin, Texas. So it's a little later over here, but I'm so happy to be here with you all. Thank you for having me, and thank you so much for everyone here being willing to, again, step forward together in this very important topic and critical area that we all have a lot of heart and compassion around. Like my wonderful mother said, my name is Jaylen Wright, and just finished, so I finished my PhD here at UT in Austin. And one of the things that I had the privilege of doing for, on top of the work doing the last 7 years I've been in Austin, 10 years in Texas, but has all been around health and well-being of Black communities, marginalized communities, Black and Brown people and families. And this last few years, or this last year specifically, my dissertation was focusing in on Black maternal health during the pandemic. There's this idea that we have been, again, studying this very critical topic for years and years, decades even, but when the introduction of the pandemic and what that meant for not only everyone in the US, the world in general, but what it meant especially for marginalized communities and those most vulnerable to these different health implications, and how the pandemic was showing up in people's lives when it comes to stress, when it comes to just overall health and well-being. And so that's where we sort of get started here. The title of my of this work and the dissertation itself was Birthing While Black, a qualitative exploration into the experiences and implications of the COVID-19 pandemic on Black maternal health and care. So the treatment that was being received during this time as well. Oops. So where I always begin with these presentations is language and positionality and considerations when we think about this topic of Black maternal health. And so in this presentation, the terms women, pregnant capable people, pregnant or birthing persons, and mothers are used synonymously in an attempt to account for the voices and stories in this study, and then to acknowledge all people who seek or provide any reproductive, preconception, prenatal, birthing, or postpartum care. All right, so we're just going to go through an introduction and background of this work. So the dissertation was focused into two studies, and then a combined findings of those, where they began to overlap, and analysis was, look at that. And then analysis brings those two studies together and looks at it from another point of view. So with this, we start with this multi-layered health crisis And we have maternal mortality and how in the US every year, 700 women die from pregnancy-related causes during pregnancy, birth, or within a year postpartum. And 8 in 10 Black maternal deaths can be prevented based on circumstances surrounding healthcare and the treatment and the care that they receive while in these spaces. So we have a visual where you can view the US maternal mortality rates and across 2018, 2019, and 2020. And this can be compared across race as well for non-Hispanic white, non-Hispanic Black, and then Hispanic Latina. What you'll see is the 2020 rate of 23.8 US maternal mortality deaths. So this is deaths per 100,000 live births. The national rate at 23.8, and then the rate for Black women and birthing people at 55.3. And again, you can see across the years 2018 through 2020, but again, the discrepancies between across race for the year 2020. And this does not take into account anything that was any death that was COVID-19 related, as well as not taking into account the different levels that within race when it comes to age and what age groups were being heavily impacted during this. So where this study and where this work was born out of was the idea that every single time someone who was Black and pregnant felt ignored, unheard, or alone, created a window into how care was being perceived and also how it can be improved. The next piece of the multi-layered health crisis was the pandemic. So since the onset of the pandemic, early analyses of the implications of COVID-19 on Black communities showed an increased number of deaths and overrepresentation of Black people hospitalized with COVID-19 compared to other races. And finally, there's this intersectionality and social determinants of health. And this has to do with the idea that further research is required attention to the complex intersectionality of pregnancy, gender, sex, race, socioeconomic status, and then how other structural inequalities have been magnified during the pandemic and this era that will follow. So where we're able to sort of look through a lens when it comes to analyzing these stories, these narratives, these lives of these individuals, mothers, and their families, we have things like Black feminist thought. We have things like Black reproductive justice. And we use these in order to conceptualize maternal health equity being the clinically and culturally competent quality with equitable and just health decision opportunities, regardless of gender expression, level of income, education, occupation, race, or ethnicity. And so for this work, I got to use this as an intersectional lens through which Blackness, womanhood, and bodily autonomy can be seen and advocated for. All right, so the total dissertation between study 1 and study 2 was comprised of about 64 individuals. And this was all done through, again, qualitative research methods. So this involved interviews with individual mothers. This involved focus groups with maternal health care workers and maternity care just providers in general. Lots of information, lots of hours, lots of time went into this work in collecting these stories and the lives of these people and how they got through this time, how they survived during this time of being pregnant or providing care to pregnant people. And this first piece, and this was a study of Carry, Labor, and Love, Navigating the Process, Well-Being, and Perinatal Experiences of Black Mothers. And these were individuals that were actually living in Texas. So this was a Texas-based study, but during the COVID-19 pandemic, and what that means when we go to generalize this type of information to the rest of the country. So some perinatal specific participant characteristics. So for this, out of the 35 mothers that participated, 57 percent, so almost over half of the mothers that participated identified as being a first-time mother, and then 2 mothers identified as giving birth across 3 different decades. So we had 2 mothers that gave birth right after 9/11, so in 2001, Then right around 2011, and then here in 2021, these last couple years, but during the pandemic specifically. And so they were able to speak across a different level of what it meant to parent and mother their children and be pregnant during these very different times in our histories here in the US. Next, we have delivery locations. So about 90% of the mothers who participated gave birth in a setting, and this is opposed to those who gave birth in a home setting, as well as giving birth in a birthing center. And then lastly, we have delivery type, and individuals that gave birth vaginally was about 60%, and that was broken down into those who utilized an epidural versus gave birth naturally. And then we have those who experienced a C-section, and this was broken down into those who experienced an emergency C-section versus a planned C-section. And one of the major outputs of this work I was able to create this national stress exposure timeline. So a lot of this study had to do with how these women, how these mothers identified the stressors that were in their lives individually, but also what was impacting them at a greater and sort of higher level sort of point. So this was created from their stories that they shared of things on during this time that were impacting their day-to-day lives, their decisions, their health, and their well-being. So here at the beginning of 2020, or in 2020, at the beginning of the COVID-19 pandemic, mothers mentioned high stress areas such as the murders of Breonna Taylor and George Floyd. They're all at the beginning, again, of the pandemic, happening at the same time of the national sort of shutdown and shelter-in-place mandates and policies. We then shifted into the summer of nationwide Black Lives Matter protests and what it meant to be Black, be pregnant, and be a mother during this time. Those with Black daughters, those with Black sons, with Black husbands, partners, individuals in their family that they were now worrying for at another level than which they've hadn't been exposed to at this national rate, even though these things have been going on again for centuries, for decades. There was a different twist of what it meant to be going through this during a pandemic and this moment in time. Next, we had here in Texas specifically was a winter outbreak that hit Texas that Texas is not totally prepared for, was not prepared for. And so how that displaced families. But when we think about at a national level, we have things like people's day-to-day lives and their families that displace them every year. And so this is specifically what happened to Texas, but these kind of national things that have to do with weather or that have to do with just other national crises, they take place, of course, in these other cities and states and areas that we call home. Next, we had the nationwide coverage of infant formula supply shortage. So for mothers who decided that they wanted to choose not to give, provide breast milk or just overall breastfeed and body feed their children or their infants, this was something that was a major crisis for them. We have mothers that didn't have the ability to do this physically, mentally, and then we had mothers that actually chose that this was not the best option for them, for their health and well-being, to breastfeed as an option. And so when we think about things about infant formula supply and what it meant to utilize that as a stressor, or to name that as a stressor to their mental, physical health and well-being, and how that impacted and going through during this time and having access to this type of these type of resources. There's a lot of fear. There's a lot of ideas around how they were going to feed their family, how they're going to feed their child during this time, and what that meant for the mother and the infant's well-being as well. And then lastly, things that again impacted the nation, but were very prevalent for the mothers that spoke them here in Texas, was the mass shooting at the Buffalo supermarket and then Uvalde Elementary, and what it meant for people in their children's friends, people in surrounding families and communities, as well as their own families, as when it comes to the fear around going back to supermarkets, going back to grocery stores, again, day-to-day decisions and things that were being impacted. Oops. And then the Texas abortion trigger law, as well as the overturning of Roe v. Wade. These were also noted as high-level stressors that mothers were contemplating and trying to sort of navigate during this time of whether they're in their postpartum period or their pregnancy portion of their timeline. So these are major narrative findings. So based off of the stories and how they told them stories and the context in which they shared their lives with me during this time around this topic. We have 8 dimensions of well-being of the Black mothers in this work. And what this had the ability to be broken down into were things that challenged. So things that challenged these dimensions of well-being and things that cultivated it. So we have physical well-being, emotional well-being, social, environmental, intellectual, occupational, financial, and then spiritual well-being. And I'm going to just hint on or touch on a couple of these. So for emotional well-being, we have things that challenged it, such as trauma, loss, and death, events of racial injustices during this time, perinatal specific distress, such as perinatal depression, anxiety, overall rage, things like that when it comes to emotional health and well-being, and challenging that aspect, everyday discrimination, and then asking for help. And then items such as psychological safety, trust, and authenticity with families and with their family, with their partners and communities and their service providers. Just to shed light on what was specifically shared by mothers who participated. One mother talked through the racial injustices, COVID, and then her pregnancy anxiety. And she mentions that I think it was COVID. I think it was the killings of unarmed Black people. I think it was my situation in grad school. I'm fighting racism with my professors. I'm fighting racism with my peers. But I think that plus being pregnant, plus the hormones, these were all things that were contributing to her pregnancy anxiety. And this sort of felt perceived inability to ask for help when she is not receiving the care that she felt like she deserved. She's not, these things are going untreated. These things are going undiagnosed and unable to get help for. So you only know what you know. And this was something that caused a lot of distress for her. And then on the other side of this spectrum, we have things that cultivated well-being. And so this was another mother who identified as a first-time mother here in 2022. And she talked about how sharing an identity with her provider was able to, be another thing that cultivated things like psychological safety and trust. So she mentions, I definitely wanted a doctor that was well-versed and kind of an expert in high-risk pregnancies. And the doctor had to be Black, a Black physician. That was a non-negotiable for me. And so one of the things that contributed to something that cultivated emotional well-being for her and this psychological safety and trust with her provider was their identity, was their racial identity specifically. We had mothers talking through how if they worked with a doctor that was a Black woman who also identified as a mother, what that meant for them to see themselves in their eyes, what that meant for them to see themselves with a doctor that can share different aspects of their own lives with them in a way that made sense, in a way that culturally grounded them, and saw them again as a human, saw them again as a person and not just a number or a statistic sitting in the room with them. We had mothers talk through what it felt like to be in a doctor's office and say that they felt like they were just part of the room. They felt like they were a piece of furniture in this room. And that treatment, this type of treatment can go between their medical providers and their doctors. This can be something of things that happened or things that providers did or did not do. And so we'll see that here in this next piece when it comes to what challenged intellectual well-being. And next slide. So things like obstetric discrimination, vaccine choice, disregard for birth plans, unawareness of perinatal care options, dismissal of spoken feelings, and then dehumanization. One of the major aspects of this is obstetric racism and discrimination. So obstetric racism rests that hierarchies have led to differential practices, tasks, and clinical decisions. And so this describes this interconnection or intersection of obstetric violence and medical racism. And like I mentioned earlier, it's described as racist overt or covert treatment from healthcare providers and staff, including those who may be withholding information about treatment choices, those who may be refusing to listen to their concerns and their symptoms, and those treating them dismissively or disrespectfully, and even getting to the level of shouting at or threatening their patients, specifically Black and Brown mothers and pregnant people during this time or during these appointments. Mothers who spoke on this area, this mother talked through not having a say and how it's just that it was a traumatic experience for her. This was giving birth. She went from thinking she was going to have a natural delivery, a vaginal delivery, to having to have a cesarean, so a C-section, and how it wasn't a good experience. This mother talked through not being educated on her options when it came to labor and delivery. So getting there, getting ready to have my daughter, I just kind of felt rushed towards the end by my doctor. I didn't really know all of my options. They were not laid out to me. And she was not aware of the fact that she could go to a hospital, she could deliver at a birthing center. And so when it came to things that challenged well-being for these mothers, on top of obstetric discrimination and vaccine choice, there was this disregard of birth plans. There was this idea that perinatal care options were not being educated and taught, and just sort of informing these mothers during their time and what their options were, and a dehumanization in the process of this care treatment. Next, we have what cultivated it. Intellectual well-being. So this mother talked through just overall birthing care, support options, and then autonomy. And she went on to say how it went all back to my choices, knowing my options, and again, having that support. And I think after having birth now 3 times, there are different pockets of support that are needed in giving birth. And there's a certain thing that I may need from my physician. She felt heard, and she felt like, so when she worked with midwives, and after working with her provider, she's ended up seeking midwives for her most recent birth in 2021. And she talked through how she felt heard, and she felt that the care was truly centered around her and the baby, and not just the baby. And so having the support of her medical team, her clinical staff, and then her personal support from her partner, her doula, her midwife, her family life, and all of that, how it all matters. So intellectual well-being had to do with, and cultivating it had to do with receiving perinatal education and information to then make knowledgeable decisions about themselves and for their families with autonomy and respect in the process. And then the next part, this next phase of this work was talking with maternity care professionals who provided care to Black mothers and birthing people during this time in the pandemic. And the type of professionals that I had the opportunity to speak with were ones such as city public health officials all around the state, doulas, lactation consultants, maternal health and care researchers, mental health therapists, certified midwives, and then registered nurses. Out of the 29 individuals I spoke with, about 19 of them, or about 20 of them identified as Black women, and then 26, so 90% identified as women, and then 3% identified as men. And these were all done through individual interviews as well as focus groups, and getting these individuals together to speak on this topic, to speak on these different experiences that mothers were going through, and pregnant people were going through during this time. And the major narrative findings from these conversations with the maternity care providers had to do with navigating birth work before and during the pandemic. These were broken down into things such as the call to the work and the line, the type of birth work professionals that they were, and the journey to this line of work. The work itself, where it was the services provided and how that work was carried out, and the best practices that were performed during this time and before. The barriers to the work, so cultural differences and unmet expectations, and such as like challenges on the jobs and the support needed during this time. And then finally, the outlook. So this had to do with legitimizing their profession and prioritizing Black maternal health in terms of the future of healthcare practices and political systems. Just to touch on a couple of these ones, this was shared with me by a full spectrum doula who identified as a Black cisgender woman. And she talked through the history of traditional birth work and doula work and said how, based on the history of birth work and doula work, my people and my lineage were out there doing doula work the way the hospital system actually and the way the hospital system actually grew and became to be what it is was, one, learning from midwives and doulas, but then taking that knowledge and creating barriers. For example, if you were not white, you could not practice. So then Black folks were not able to become doctors or work within hospital settings. And this set up home births, midwives, and doulas to be viewed as unsafe environments. So just knowing some of the legislation and barriers that have been put in place to have birth work where it is today, it feels kind of like creating more barriers for people who are trying to get into the work in this field again, who look like us. So when she talked through these legislation and these barriers, she was mentioning for both doula work, for a lot of different nursing certifications, for midwifery, how certifications, credentials, hospital access, privileges, these were all things that were being, have been enforced over time, and then also isolated sort of events over time that made it more and more difficult and challenging for people, again, who look like us to get into this work. Different types of education, different types of training that is now being required in order to gain these credentials and hospital access. But also the criminalization of these birth work professionals, where a lot of areas, not just in the South, like in Texas, but a lot of areas throughout the country have deemed it illegal for them for midwives and doulas to set foot in certain hospitals, and again, criminalize the act and the practice of these birth workers. And so talking about the call and the journey to this line of work, it all had to do with these individuals who share their stories, all had to do with being determined to demystify the pregnancy, laboring, and postpartum process that makes space for mothers and their families to be vulnerable, educated, and then supported. And second, the second piece was said by a certified nurse midwife. And she talked through how in midwifery, that's just the motto, listen to women. And I really feel that that's emblematic of what we do. I think our perspective is very focused on being engaged with the woman as a part of, as a partner in her pregnancy, birth, and postpartum experience, rather than as just someone that these experiences are happening to. That we're not the expert, but we're truly just engaging with her. And we want to educate her so that she has a lot of knowledge when we get to the point of delivery, and that she can ask intelligent questions, and that she doesn't feel lost by the environment or what's going on in the process. And so this, when talking about the work, talking about the service that was being provided, this had to do with speaking on their best practices and mitigating the loss of humanized care, again, prior, during, and post this height of the pandemic. And just to wrap up this work was combined findings. So this involved doing a comparative analysis across all individuals who shared their stories, shared their lives with me during this process. And sort of some next steps in what we look at in terms of models of care. And so a birth justice safety circle was created and developed as a social, emotional, and cultural contribution to future models of care. And so again, this identifies everything that was shared with me from the mothers and from the perspectives of what was observed in terms of the best practices around maternity care by the professionals themselves. This was broken down into this acronym, SAFE, and these were sentiments of mothers and birth workers, such as support. And this had to do with establishing relationships with other mothers, birth worker communities, and creating foundations of comfort when seeking support, such as tangible, emotional support, information, and then social connectedness. We then had autonomy. So one example of this was being encouraged to speak up when experiencing mistreatment or violations of personal safety when receiving or providing care. And this includes the ability to have an advocate present to do so, because like we can remember during the pandemic, or for those of who may not have been aware, how during the pandemic, in terms of hospital deliveries and different types of perinatal appointments, support people like doulas, midwives, and again, also family members were not allowed to enter hospitals. We're not allowed to enter with these mothers to give birth, to go be there during ultrasounds and different postpartum appointments as well. And so this isolated mothers, and this gave them this sort of, again, was a loss of someone to advocate for them, and emphasize this idea around what self-efficacy meant in these spaces if they did not have someone there with them to support them during a very vulnerable time in their lives, and health decision-making that could all contribute towards healthy striving and health literacy in this field and in this process. We then had faith. So what faith meant for these mothers, and what faith meant for a lot of cultural components and contexts, had to do with acknowledging, accessing, and offering various formats of spirituality and healing practices. This was centered around hope and gratitude, wisdom, and healing practices that mothers shared got them through this time, that providers shared that got them through this time, but also was observed when it came to caring for mothers and what was being valued during those appointments. And finally, we have equity. So this had to do with receiving culturally congruent care and education around Black maternal health and the unique perinatal experiences of Black women and birthing people. So whether it was training, education, treatment, and then research funding of this type of work, these were all things that centered on equity across the board when it came to for both mothers and those who provide care to them. And this was a mental health therapist who, a Black woman who talked about this return to old school community-based mothering support systems. And it sort of captured the entire birth justice safety circle sentiments and the components of it. And she talked through how the biggest thing that I think that has been said by her Black clients was that they need support, and not just blanket support, but support with the day-to-day. And what she's commonly heard is that they are the ones that are always thinking about what everyone else needs, and no one really considers theirs. When she ends up asking, what do you need? It's funny because they will say, well, I need help with my other children. I need help with food, or help with this or with that. But they almost immediately take it all back, like it's something that they don't deserve, or even can have, because no one extends it to them. The biggest thing that comes up almost for each of them is that tangible support, people to be the hands and feet of their homes, someone to do the dishes, someone to do the laundry, just tangible things that they can feel and that they can experience. And it reminded her of the old school before my time, probably her mom's time and her mom's time, how the community truly rallied around you. And you had people bringing over meals and coming over and maybe even watching the other kids. But we don't have that same type of support right now, and acknowledging that the pandemic even caused it to be more isolated. Even so, if you did have the people who could provide it, you couldn't truly reach out to them because you didn't feel safe in the process of doing so. So needing people to be there and people to show up and do things without the mothers always having to ask felt like this, again, a return to old school community-based mothering support systems. So that is the end of the presentation itself. But one of the ideas that I always want to just remind as we move forward were things like when you're too uncomfortable to talk and you don't know what to say. What got me through this study, what gets us through this work is listening. And a lot of what's inspired this work again also was this idea around qualitative change in our souls leading to quantitative change in our lives. And that's why I want to thank Maikisha for sharing the story behind April and their families and your families, because to humanize these experiences, to humanize these numbers that we see that are discrepant, that are traumatizing, that are heavy, but to remind ourselves that these are people, this is our And these are our neighbors, these are our families, these are our sisters, our mothers, our daughters that are being impacted by this every single day. And it means a lot for me to know that everyone on this call has prioritized this in their lives, especially right now here today. And I appreciate that I'm being welcome to also continue on with this work and share it as well.
I want to say thank you again to Dr. Wright. We will be coming back to asking you some more questions during the open panel, but amazing presentation, the information that you covered, it just so much to digest and unpack. So we're going to probably have a few questions during the panel.